Professor Dr. Ateeq Rahman to share his valuable insights.
Bismillahirrahmanirrahim. Assalamu alaikum to all. Diabetes and oral health is basically a two-way process. Oral health is not limited to our oral cavity. It basically reflects our overall health. If our oral health is in good condition, our body will be in a good medical condition. So I chose this topic of diabetes and oral health as a two-way process. This is very interesting. Diabetes and oral health is basically a two-way process, a bidirectional relationship. As a slight increase in blood sugar level deteriorate our oral health, and conversely, our poor oral health lead to increase in hyperglycemia. So first of all, we know there are millions of cases of undiagnosed diabetes. Here I prefer to use the term dysglycemia because dysglycemia encompasses both pre-diabetic and diabetic cases. So there is a good news that oral health care providers can detect or diagnose diabetes at an early stage, and it will be fruitful for our patient to prevent from future life-threatening complications. As this patient, 40 years old, presented to dental department of Allied Hospital, Faisalabad, with chief complaint of just bleeding gums and enlargement of gingiva. But on intraoral examination, there is a specific pattern. There is gingival enlargement with sessile or pedunculated appearance, multiple abscess formation in the oral cavity, and there are also oral ulcers in the oral cavity, and patient mouth is dry comparative to normal patient. So there is suspicion of diabetes in this patient, which actual complaint is just bleeding gums. But as a dentist, we can screen these patients early and can prevent them from future complications. So I refer this patient to medical physician, and thereafter blood glucose test, specifically HbA1c, the patient declared as diabetic, and his HbA1c level was 7. This is very interesting. That patient was passing a life without knowing his medical condition. So we, as oral health care provider, can detect or diagnose the disease at an early stage. And one thing is very interesting in this, the two-way process is basically related to inflammation and inflammatory mediators like tumor necrotic factor alpha, interleukins, MMPs. There are plethora of cytokines which are involved in two-way process or bidirectional relationship of diabetes and oral health. So the objective of my presentation are to highlight bidirectional relationship between diabetes and oral health, identify common oral health problems in diabetic patients, and last, explore the role of dental professionals in diabetic management. Bidirectional relationship. This is very important. Usually patient complications from diabetes are diabetic retinopathy, nephropathy, microvascular, macrovascular complication, delayed healing. But currently, the sixth complication of diabetes is periodontitis. That is very important. The sixth complication of diabetes is declared as periodontitis, which is basically mobility of the teeth, infection in the gingiva of teeth. And also, diabetes is the only chronic disease that is a risk factor for periodontitis. This is very important. There are a lot of chronic diseases, but diabetes is the only disease that is a major risk factor for periodontitis and oral health. Oral health and HbA1c. This literature research must be in your mind that after just teeth cleaning, the HbA1c level will drop. After 3 months of dental treatment, people with diabetes had a mean reduction of HbA1c of 0.3%. That is very interesting. Just after teeth cleaning, the HbA1c level drops to 0.3% after 3 months. And after 6 months, the average decrease in HbA1c level was 1% and 0.8% respectively. The reference is from International Journal of Molecular Science, and it reflects the importance of hygiene can improve your glycemic levels. Another research, after 3 months of teeth cleaning and dental scaling, the mean decrease in HbA1c level in diabetic was 0.3%. A 1% reduction in HbA1c level resulted in 37% reduction in microvascular complication and a 21% reduction in diabetes-related deaths. That is very interesting. References from Journal of Oral Rehabilitation. This diagram is very important, reflecting the bidirectional relationship of diabetes and oral health. This is example of type 2 diabetes involving the beta cells of islets of Langerhans. If there is a dysfunction of islets of Langerhans, then there will be increase in AGEs. The main target area in diabetes is AGEs, advanced glycation and products which are due to glycation of proteins and lipids. Usually the receptors of the AGEs are on the macrophages, but in cases of oral cavity, their receptors are also present on the gingival epithelial cells, periodontal ligament cells, alveolar bone, and ultimately there is direct relationship and direct destruction of periodontal attachment and bone loss. Also there is defect in neutrophil chemotaxis, phagocytosis, and there are primed macrophages. So the diabetes basic target area is collagen. Collagen, which is basically a supporting structure of our teeth, is destroyed in diabetes. There is no synthesis of collagen, and old collagen is very weak in diabetic patient. The ultimate results in production of plethora of cytokines, interleukin 1, TNF alpha, which ultimately result in periodontitis. And periodontitis, the main major bacteria are gram-negative bacteria with a specific tool of endotoxins that lead to reactive oxygen species, increase in interleukin 1, TNF alpha 1, increase prostaglandin E2, decrease adiponectin, and systemic inflammation. All changes ultimate results in insulin resistance, impaired glucose homeostasis, which results in type 2 diabetes. So this is a clear-cut explanation of bidirectional relationship of diabetes and oral health. The main area between both is inflammation. Inflammation drives the severity of hyperglycemia and also destruction of oral health. Clinically, there are specific manifestations of diabetes in our oral cavity. The most common is gingivitis, periodontitis, alveolar bone loss, mobility of the teeth. And a very interesting manifestation is xerostomia, dry mouth. Xerostomia ultimately results in multiple tooth decay in oral cavity, oral ulcerations due to friction in the oral mucosa, and increased risk of oral infections. As in diabetes, there is defect in chemotaxis, phagocytosis, there is chance of opportunistic infections, specifically candida infection. Candidiasis is prevalent in patients of the uncontrolled diabetes. This is very interesting, as in last lectures, the presentation of diabetic foot, so I correlate it with diabetic pulpal necrosis. The pulp, which is the core of the tooth, has no collateral blood supply. Blood supply is very limited, and in diabetes there is target area of microvascular and microvascular. Ultimate results in ischemia of the tooth structure and pulpal necrosis. And in this intraoral radiograph, there is periapical lesion. Patient present with abscess formation without any tooth decay or history of trauma, but his medical history reflect uncontrolled diabetes, which results in necrosis of the tooth. So the ultimate treatment will be root canal treatment or extraction of, in this case, just due to uncontrolled diabetes, the patient can lose one or multiple teeth. What is the role of dental professional in diabetes? That is very important. And the first line is early detection of diabetes is very important. We, the dentists, can detect the disease at an early stage and prevent the patient from future complications and life-threatening conditions. Second, management of oral health complications like tooth decay, oral ulcers, candida infection, periodontitis can be managed by dental specialists. Patient education is of paramount importance. Patient education in this regard is very important to highlight bi-directional relationship of diabetes and oral health. Managing the dental procedure is very important. If we do any procedure without controlled glycemic level, the ultimate result will be delayed wound healing and multiple. Managing the dental procedure is very important. If we do any procedure without controlled glycemic level, the ultimate result will be delayed wound healing and multiple complications. So we always prefer to treat our dental patient under proper glycemic control. And last is promoting the preventing care is have pivotal role in diabetes and oral health. Prevention is the key to success in this regard. Proper teeth brushing, dental flossing, use of antimicrobial mouthwash, brushing the surface of tongue, all are prerequisite for good oral health and also good glycemic control. Summary, all points I mentioned are basically related to bi-directional relationship between diabetes and oral health. Second, sometimes patient chief complaint is just bleeding from the gums or mobility of the teeth. So only this sign can be danger sign for the patient when we have to check it. Last is caution needed in treating such patient for dental procedure. If we treat patient with uncontrolled diabetes, the ultimate result will be delayed wound healing, persistent infection, and poor results of our surgical or non-surgical procedure. So hopefully this will be fruitful to you. Thank you.